Have you ever been confused about certification, which certification exam you should take? There are so many out there. Every specialty has a certification exam, but sometimes you wonder, are these nationally accredited exams? If I move from Massachusetts to Nevada, will that certification exam serve me well? There are 3 very large sanctioned national examination organizations that if you take their examination, you will be golden. That's the BCEN, AACN, ANCC. Those are nationally accredited, sanctioned organizations that give examinations. Hi, I'm Cami Christie. Please join me with MedEd. Get your certification review in preparation for a sanctioned national certification.
Hi, welcome to MedEd's production of the CPEN exam review. My name is Beth Paton, and this module is called Shock Recognition and Management. The objectives for this presentation is I'm going to define different types of shock, describe how to recognize shock in children or pediatrics, and discuss pharmacological and non-pharmacological management of shock. So first, let's give a definition. Definition of shock. It's the inability of the peripheral blood flow to return blood to the heart for normal function, particularly transport of oxygen to vital organs and tissues. So that's your Webster's version. There's different types of shock. First of all, we're going to talk about compensated versus decompensated shock. Compensated shock, signs of that, the child will be tachycardic. They'll have peripheral clamping down, that is, their vasoconstrict, maybe they have delayed capillary refill, extremities might be cool, blood pressure still normal. And they may or may not have a normal appearance. They might be a little bit sleepy or a little bit fussy, or they might appear normal at this stage. It depends on their age and the rationale or the etiology behind their shock. Decompensated shock, their appearance is definitely abnormal. Their mental status will be abnormal for sure. And the key difference between compensated versus decompensated is that they will be hypotensive. And remember, you have to lose approximately 25% of your blood volume before they show signs of blood volume loss. And remember, the normal blood volume for a child is 80 cc's per kilo. So if you think about it, that's not a whole lot of blood. And at this point, the blood pressure is below the 5th percentile. And their level of consciousness will for sure be altered at this point. So our goal is to not let it get to decompensated shock. Hopefully we'll learn some tips to intervene long before that ever happens. So failure to treat shock aggressively and early can lead to renal failure. So basically it's in-organ damage. So because when your body is in shock, it starts to prioritize, like, which body system do I care about the most, which one do I care about the least. So if you are perfusing everything, you're good. If you're not perfusing things, then the body's like, I don't care about this, I don't care about that. So basically the biggest thing it cares about ultimately is the heart. So failure to treat shock can lead to renal failure, brain damage because it won't perfuse the brain like it needs to, gut ischemia. Your gut for your body does not think it's essential, so it'll hypoperfuse the gut and lead to ischemia. Liver failure certainly, and some of it's because it's not perfusing, but also sometimes some of the things that are broken down during the shock phases will accumulate in the liver and cause liver failure. You can certainly have some metabolic derangements, DIC or disseminated intravascular coagulopathy, ARDS or respiratory distress syndrome, cardiac failure, and then ultimately failure to recognize and failure to intervene can lead to death. Let's go over some pathophysiology. So how does your body respond? What are the physiologic responses to shock? First of all, increased capillary permeability. So what does that mean? In what scenario would you see that? So if, let's say you have a child present in shock and you're giving a lot of volume and you're fluid resuscitating them, if you notice that at some point they start getting really puffy, edematous, develop periorbital edema or soft tissue swelling, well, that's that capillary permeability, because the blood vessels, especially in the periphery, become leaky and you get loss of fluid in the interstitial space, which is not where you want it. You want it in intravascular space for volume expansion as opposed to interstitial space. Initiate develop of microthrombi, and that's what leads into DIC, because all the clotting factors get caught up in the microthrombi, and therefore they're not out in the systemic circulation to work like they need to. Bronchoconstriction, vasoconstriction, so that's that clamping down, because basically vasoconstrict to be able to shunt blood to the more vital organs, and then decreased response to catecholamines. So basically your heart rate's not able to increase like it's supposed to. You're not able to compensate for things as well as you're normally able to. So stages of shock, we're going to go over the initial phase, compensatory phase, progressive, and refractory. Initial phase. During the initial phase of shock, you have decrease in cardiac output, impaired cellular tissue perfusion, and decreased aerobic metabolism. So you're not able to ventilate, oxygenate as well, cardiac output is not as good, tissue perfusion is altered. In response to that, you have increase in the anaerobic metabolism, so that's where you start developing like metabolic acidosis because you have increased lactic acid production as well. So between the anaerobic metabolism and lactic acid production, these are the things that start to impair the liver and start to increase the metabolic acidosis. Compensatory phase. So this phase, your body's trying to really start to compensate. Like, hey, I don't have enough volume, or hey, I'm septic, or my spinal cord's injured that I can't compensate. So your body's trying to compensate for that. So it's trying to respond to the impaired tissue perfusion and impaired tissue oxygenation. So the first thing it does is try to shunt blood. So you get the peripheral vasoconstriction, increasing your heart rate. So you try to increase the preload to the heart, and then increase cardiac output to try to increase the afterload as well. So you shunt the blood to try to, again, perfuse those vital organs. And with that, it's the sympathetic nervous system response as far as increasing the heart rate, vasoconstriction. And then you also have some hormonal responses that occur. And it's amazing how complex the body is. I mean, it has all these mechanisms to try to compensate, which is really cool. So the renin-angiotensin-aldosterone system, and then also antidiuretic hormones. So antidiuretic hormone is what regulates how well your body, basically it's your fluid balance. So if you have hypovolemia, your body's like, hey, I need to hold on to as much as possible, so it triggers your kidneys to not diurese as much and hold as much volume as possible. And then therefore you might see as a result of that oliguria, because again, your body's like, I need every little bit of volume I can have. Compensatory phase, also with that, all those compensatory mechanisms, you'll see fluid shifts. And the goal of that is to increase your intravascular volume, increase the return to the right side of the heart, which is your preload. And then you want to increase your cardiac output by increasing your blood pressure. And you do that by vasoconstricting and then trying to get as much return back to the heart as possible. If you fail to intervene or recognize the compensatory phases, then they move next into the progressive phase. And at this point, your compensatory mechanisms start to fail. And this is the phase that scares people who don't take care of kids. People are like, I hate taking care of kids, and this is why. Because they compensate so well. They've got healthy hearts, they've got healthy kidneys, they've got healthy blood vessels. So when that starts to phase, that starts to fade or fail, that happens really hard and really fast. So they're doing great, and then all of a sudden they're not. And be able to recognize the subtle things of when they're compensating and not wait until they're in the decompensating phase or progressive phase is ideal. So during the progressive phase, you have decreased cardiac output because remember, like I said, all those compensatory mechanisms with your sympathetic nervous system and all the hormonal changes start to fail. So you have decreased cardiac output, decreased blood pressure, so this is your decompensated shock where they become hypotensive. Decreased oxygen supply because you're obviously not perfusing the tissues like you need to, impaired gas exchange. Your brain, you'll start to have an altered mental status because again, decompensated shock, so you have an altered mental status, and then decreased coronary artery pressure. And then we talked about capillary permeability, so now it's really becoming more pronounced and more profound. So you have a lot of third spacing of all the tissue, all the fluid in the interstitial space. Your cells are very leaky, so again, just, they really just are failing in general. You have relative tissue hypoxia, and then because your body is really like it's trying to find anything it can to metabolize for energy and perfusion, you'll have building up of metabolic acids. What happens if you still, either the patient still hasn't presented to you at this point, or again, failure to intervene, or let's say for some reason their body just cannot recover, then you move into the refractory shock, and that is irreversible. Extreme hypoperfusion, multi-organ system failure of liver, kidneys, brain, and then, death will be the outcome of this. So ideally, you recognize it very early, intervene very early, very appropriately, deal with the underlying cause of shock, and hopefully you keep your patient from ever entering refractory shock. So those are the phases of shock. These are the different types of shock. So hypovolemic is caused from volume loss, and volume loss can be blood or vomiting or diarrhea. The typical blood volume for a child is 80 cc's per kilo. Then you have distributive shock, which is caused from decreased vascular tone, so the inability of the body to vasoconstrict and improve perfusion. And then cardiogenic, which is from heart failure. So let's do this in a couple scenarios. So scenario number 1, a mom brings her 15-month-old in with a history of diarrhea for 5 days. Today he wouldn't wake up for mom. So what else do you want to know? So what are some qualifying questions you need to do to decide? Because this child could look amazing and maybe just sleepy, maybe mom gave him something. So what are some clarifying questions you can get during your history? So first, how many times did they throw up, and what was the characteristics of it? So mom said he threw up 5 times today. It was non-bilious. The diet quantification. So quantification is so important because most parents will say, well, how many times did I throw up? Oh, a bunch of times. Or every time they ate. Or every time I changed their diaper or whatever. So the more you can get them to guesstimate a number, that gives you really an idea of, those are good clarifying questions. So she relates that he had 20 episodes of diarrhea. It was watery, but there was no blood. He's had no fever, no abdominal pain. And you ask her about urine output, but she really doesn't know, because you can imagine if you had 20 diarrhea stools, I mean, who knows if there's any urine mixed in there or not. So she's really not sure about that. So what's your exam? So the child is lethargic, and remember lethargic, be careful with using that word. Lethargic is they're sleepy, they don't want to wake up. You give them painful stimulus and you get minimum response to that. His cap refill is delayed at greater than 5 seconds. The skin is mottled, so you can tell he's hypoperfused. Pulses are weak and thready, so poor peripheral pulses, and they're very thready. And vital signs, he's tachycardic, heart rate is 200, which is much too high for a 15-month-old. A little bit tachypnic at 32, but not too bad. He is afebrile with a temperature of 37, and blood pressure is 50/30, which is low for a 15-month-old. So, questions for you. Is the child in shock? What do you think? Yes or no? I would say yes. What type of shock? Is he hypovolemic, distributive, or cardiogenic? Well, I gave you all this volume that he was losing through diarrhea and vomiting, so clearly they're in hypovolemic shock. Are they compensated or decompensated? Are they hypoperfused? Do they have an altered mental status? And is their blood pressure normal or abnormal? He's lethargic, he's tachycardic, delayed capillary refill, and blood pressure was low at 50/30. So that describes decompensated shock. So what do you want to do? So do you think you could just oral rehydration, give him some fluids, it'll be okay? Or do you want to do something more than that? So he is indeed in hypovolemic shock. It is the most common cause of shock in the out-of-hospital setting. Causes include hemorrhage, so significant bleeding, gastroenteritis, which is the scenario that I'm describing, and burns certainly, because you can lose a lot of fluid with deep partial thickness burns. Those tend to weep a lot, and they'll become hypovolemic secondary to that. So what do you want to do for this baby? Certainly position him, position of comfort, or Trendelenburg perhaps even. Put him on oxygen. If you are hypoperfused, I don't care, oxygen is a great drug. Remember that you have impaired tissue perfusion, and so therefore oxygenation, so they should absolutely be put on supplemental oxygen. In addition, I described the child's lethargic, so perhaps they're not keeping their airway open, so you should probably open their airway up a little bit and put them on oxygen. Careful assessment of neurological status, cardiovascular status. And then the biggest thing is they're hypovolemic, so we need to restore volume. So you can get an IV access in prompt right away, large bore IV, and preferably as central of a location as possible. And then you're going to give them fluids. Ideally, this child will get a 20 cc per kilo bolus of a crystalloid, such as normal saline or lactated ringers. They will likely need more than that. Anytime you perform an intervention, you're going to reassess. So we'll start off with the 20 cc per kilo bolus of, the child's not febrile, so if you're going to give him several fluid boluses, you might consider giving warm fluids. So you'll administer 20 cc per kilo bolus of normal saline or LR, and after you do that, you're going to reassess. How's their mental status? Never forget to reassess that. What's their cap refill? What's their blood pressure? The heart rate? Likely this child will need at least 2 or 3 boluses to really return them to the normal volemic state. And your best parameter of that will really be what their mental status is. Okay, let's do another one. Y'all did so good on that one. Okay, 2-week-old baby presents with grunting, mottled skin, and poor feeding for the last 2 days. So what questions do you want to know? What are some history questions you want to ask? So get them to quantify the not taking feeds and spitting up. So have they been vomiting at all? His mom describes that he's been spitting up occasionally with feeds, not projectile emesis or anything, but is having some spitting up. Get them to quantify what the poor PO intake, what does that mean? So normally the baby takes 3 ounces every 3 hours. Today he has only taken 2 or 4 ounces total all day long. Have they been voiding? So what's the urine output been? So they've only had 2 wet diapers in the last 24 hours, which is, markedly decreased. Have they had any fever? Mom describes they felt a little bit warm yesterday, but she couldn't find her thermometer and didn't check it. And what's their birth history? Were they full term? Were they vaginal delivery? Were there any complications? Did mom have any infections or fever? So she describes as full term vaginal delivery, no complications. Your exam, the child's listless, so sleepy, just doesn't really want to respond, hypotonic. He's grunting, mottled, cap refill is delayed. Pulse ox you won't pick up, which that will be true. If you have someone who's vasoconstricted, has a lot of peripheral vasoconstriction, a lot of times that pulse ox won't pick up. Lungs are cleared to auscultation. Cardiac-wise, you don't hear a murmur. They are tachycardic. And your vital signs, their heart rate's at 180, respiratory rate's 55, temperature's 36, so a little bit low, and blood pressure 70/40, which is about right for that age group. Maybe a little on the low end, but not bad. So what things do you think this baby could have? So I would think about, well, they've been spitting up and not taking their bottle as well. Could it be hypovolemic shock? It's possible. I would think about cardiogenic shock, but their heart rate was normal. I didn't hear any murmurs or rubs, so that's still possible, but not quite certain. It's a 2-week-old who's mottled, who's grunting, maybe felt warm at home yesterday. So one of the things that are high on my differential would be sepsis. So what are the nursing interventions? We're always going to put these patients on oxygen. That's key. So anticipate this child's going to get a workup. They're only 2 weeks old. They're hypothermic, which is often an indicator of sepsis in babies. So I would anticipate they get a CBC blood culture, they'd get a urine culture, IV antibiotics. They might need a spinal tap, although be really careful in a baby with this scenario performing a spinal tap, because if they're that listless and hypoperfused, the risk of apnea is pretty high. And you think about the curling up in a little ball that they have to be for a spinal tap, so their risk of apnea would go up even more with that. So anticipate all those things happening and going from there. So this child was indeed in septic shock, which is a form of distributive shock, and it's caused by decreased vascular tone. So if you're septic, you have they have kind of more leaky blood cells, are not able to vasoconstrict as well. Other causes of distributive shock, in addition to sepsis, can include anaphylaxis, drug overdose, and spinal cord injury. So with sepsis, it causes the release of many vasoactive mediators, which then leads to profound vasodilatation. That is what makes it an aspect of distributive shock. And basically with that, just all these inflammatory mediators are released. That impairs cardiac function and impairs your cardiac output. And so certainly you have to do frequent cardiac assessments as well. Another form of distributive shock would be anaphylactic shock. And basically with anaphylaxis, you have this massive release of mast cell inhibitors that result in this massive histamine response or release, and then subsequent vasodilatation. To diagnose anaphylaxis, there are 3 criteria that must be met. First, the acute onset of the illness, so generalized hives, itching, angioedema, which is edema to the face and lips and tongue. Respiratory symptoms, they might have wheezing, they might have stridor. They might also exhibit decreased blood pressure with that acute onset of illness. And then in addition to that acute onset of all those things that we described, then they have to have 2 of the other items. Some type of skin or mucosal symptoms, so hives or urticaria, some type of respiratory symptom, wheezing, stridor, decreased blood pressure, and maybe some GI symptoms like vomiting and or diarrhea, because part of a component of anaphylaxis is smooth muscle relaxation, so they'll have diarrhea or vomiting secondary to that. And then third item is decreased blood pressure after exposure to the known allergen. So these are the diagnostic criteria for anaphylaxis. In terms of management, epinephrine is key. Give that early, give it fast, give it as soon as possible, give it the second they walk in the door. The dose is 0.01 milligrams per kilogram. It is given intramuscular. Maximum dose is 0.5. And you use your 1 to 1,000 epinephrine. classic place or most easiest place to administer it is the outer thigh, and that's where parents who get sent home with an epinephrine pen or a rapid auto-injector of epinephrine, that's where they're designed to give it. And then you want to certainly do rapid airway management, give them oxygen, open their airway, anticipate taking control of the airway if there's any risk. Elevate actually the lower extremities because that will help with your blood pressure because like I said, they are hypotensive. And you'll go ahead and give a 20 cc per kilo bolus of normal saline because you just want to add volume because they're not able to maintain volume themselves or compensate for that. If after you give that epinephrine they still have bronchoconstriction, they're still wheezing, still have difficulty breathing, then nebulized albuterol would be warranted. You also want to give them an H1 blocker, which is diphenhydramine, and that's given IV because all these things are going to be IV or AM because you're not playing around in this scenario. Like you want these people treated as quickly as possible because the quicker you intervene, the more aggressive you are, the better they're going to do. So they'll get 1 milligram per kilogram of an IV antihistamine, again typically diphenhydramine. Then they'll get an H2 antihistamine, which is ranitidine or Zantac, and you'll give that also IV. And then they need an IV steroid, which usually is methylprednisolone, 1 to 2 milligrams per kilogram, and then monitor them. Especially once that epinephrine starts wearing off, it might be that until the other medications have really kicked in and started working, that perhaps that they will have rebound or get sick again. So really, like close, careful assessments. Watch your airway, watch your perfusion. All those things are super important. All right, let's move on to spinal cord injury. So spinal cord injury, depending on the level of the spinal cord injury, they can also exhibit signs of spinal shock, which is also a form of distributive shock. So basically, depending again on the level, which is usually from injuries above your first thoracic spine or T1, you have interruption of the sympathetic nervous system. And so we talked about sympathetic nervous system with other types of shock. That's what allows you to increase your heart rate and vasoconstrict in response to positional changes. So if you stand up, you don't pass out or fall out because your body vasoconstricts and increases your heart rate in relationship to that. So patients with high spine injuries, they're not able to do that. They've lost that sympathetic vascular tone. And so then again, they can't respond to that. And the way these patients will present, so if you have a patient that comes in with a C7 fracture, that's a complete quad secondary to that, they will come in typically they'll be very hypotensive, so they'll have a low blood pressure, but the heart rate's still okay. So you'd expect, I don't know, if you had a child come with a blood pressure of 70 over 30 and they're at trauma, if they were hypovolemic, you'd expect them to have a pretty significant increase in heart rate, 160 or 170. But in this scenario, the heart rate's 90. So let's say you have normal heart rate or maybe a little bit elevated, but they're bradycardic and showing signs of hypotension, have a hypotension, then that would be it's not what you would expect. So think about spinal shock in that scenario. And when you give them saline boluses or crystalloid boluses, they don't really respond like you would expect them to. So you don't see a lot of high spine injuries in kids, but when you do see them, you want to recognize that the shock that they can present with. So if they present in spinal shock, certainly oxygen, we love oxygen, great drug. Position them accordingly and certainly avoid rapid changes in their position. Give them IV fluids, but remember they might not necessarily respond to fluids. Now if they have distributive shocks secondary to anaphylaxis, you're going to treat with epinephrine. If they're in septic shock, then they'll end up with dopamine. And then if it's spinal shock, they might need vasoactive agents as well. All right, time for another scenario. Scenario number 3. A 6-month-old presents with fussiness and poor feeding for 3 days, seemed worse today. What else do you want to know? So all these scenarios basically are things that I've seen, but this one stands out to me a little bit more distinctly because we actually had one of the reps for our stretchers brought her little girl in, and I'd met her before, and her and I share the same first name. And so she brought her 6-month-old little girl in because she's like, Beth, I just don't know what it is, but she's just fussier, she's just not feeding as well. Do you mind just taking a look at her just to see what you think is going on? So I go to assess her. I get the story. And, Mom said normally she's takes 6 or 8 ounces every time she eats. Today she'd only been taking 2 ounces and just seemed to get tired with the feed. She'd want it, but then it just seemed to tucker her out. Asked her if she'd been vomiting, and she had not. Has she had any fever, been sick at all lately? She has not, and she's still maintaining normal urine output. And again, it's one of those ones, it's like, I don't know what it is, but something just isn't right. And so always listen to parents. They're very astute. So that I go to assess her beautiful little girl. And so she is fussy, a little bit difficult to console. Her extremities are mottled. She looks good. I mean, she's awake and interactive, but she just is a little bit fussier, is a little bit mottled. Peripheral pulses are decreased. So I try to check her vital signs. I'm listening to her heart rate, and it's too fast to count. And her respiratory rate's 40. And I'm on the automated blood pressure cuff, can't pick it up. And the pulse ox, because of her poor peripheral pulses, is unable to pick up as well. So heart rate's too fast to count, unable to pick up a blood pressure, and unable to get the oxygen level, and her mental status is she's fussy and difficult to console. So, is this child in shock? Yes, no, maybe. I would say yes. So what type? Compensated or decompensated? Well, it's hard to say for sure because I can't get the blood pressure to pick up. So I think you would be safe to say that she was decompensated because I described that she's got decreased pulses and poor peripheral perfusion. And the fact that her blood pressure can't pick up, likely it's decompensated. What type do you think she's in? So she hasn't been vomiting. I'll decrease PO, but I wouldn't think that's enough to cause hypovolemic shock. She doesn't appear septic. She hasn't been sick. She's afebrile. So, but I described that her heart rate was too fast to count. So she is actually in cardiogenic shock. So different ways that can cause, or different things that can cause cardiogenic shock. Certainly congenital heart disease. Kids can have pretty significant congenital heart disease, and that can cause problems. Cardiomyopathy, myocarditis, dysrhythmias, one of which is SVT, which is what this child is in. Because I described their heart rate's too fast to count, so likely she's in SVT or supraventricular tachycardia. And then some overdoses can cause cardiogenic shock as well. So assessment findings that you might see with cardiogenic shock, altered level of consciousness because, again, impaired perfusion, might be diaphoretic, certainly a rapid heart rate, an elevated or low blood pressure. In this child's scenario, likely it's low. Might have coarse breath sounds, especially if it's from congestive heart failure. You can get coarse breath sounds with that. You might have hepatomegaly with heart failure, so the liver might be down. Cardiac gallop, you might hear a new murmur. You might see a precordial heave. If you got a chest x-ray, you might see that they have cardiomegaly, and you might have some EKG abnormalities. So your treatment's going to vary based on what this diagnosis is or what the etiology of it is. Certainly if it's, you want to be careful because if in their congestive heart failure, you might want to be careful about how much fluid you give them. If they're in cardiogenic shock from congestive heart failure, they might need some type of vasopressor, like dopamine or epinephrine, again, or dobutamine. It really depends. Sometimes we don't use dobutamine as much just because you don't want to stress the heart out that much more, but dopamine works well, epinephrine also. Certainly if they're dysrhythmias, like this little girl, you're going to treat the dysrhythmias. So how do you treat SVT? So if she is compensated, she's awake, alert, happy, which actually this child, even though the scenario I gave you showed that she was somewhat decompensated, this little girl actually looked great. She was happy, she was smiling, she was cooing, she looked fantastic. So I wasn't worried about her at all. So your treatment pathway for that would be varies based on whether or not they're in cardiogenic shock. So basic shock management, certainly you want to get a very careful history, so your assessment is important. A history is key. Usually most of your diagnosis you should be able to make without even doing your assessment. You should be able to get it based on your history alone. So get them to quantify everything, get them to qualify things as much as possible. During your assessment, get a history of any fluid losses. If they're blood loss, if they're active bleeding, how much bleeding was there, how much vomiting, how many times did they throw up, how many times did they have diarrhea. If they have decreased PO intake, what is that? How much do they normally take? What have they taken today? History of congenital heart disease, and then any potential source or risk factors. A neonate is a high risk factor for infection. If mom had any maternal infections, that makes them even more of a risk. And then what are your assessment findings? What's their mental status? I know I've emphasized that a lot, but it's because I don't think it gets documented enough, and it's such a key indicator of not only your status now, but then the success of your interventions. Are they tachypnic? Are they tachycardic? Remember, hypotension is always an ominous sign, and bradycardia is always an ominous sign because that tells you your compensatory mechanisms are starting to fail. Are there any changes in skin color? Are they super pink? Are they cyanotic? Are they mottled? Is there a change in your pulses? Or remember to assess your upper and lower pulses and your central and peripheral pulses. Are they hypothermic, which is pretty ominous? Are they hyperthermic? Is there any decrease or absent blood bowel sounds? Because that tells you your body is not perfusing the gut. Or is there absent or decreased urinary output? Because then you'll see that with hypovolemia and an action of your antidiuretic hormone. Okay. What lab findings might you see? So CBC, are they anemic? Do they have a high white count that tells you they're septic, or a low white count, which is also a sign of sepsis? Is their hemoglobin hematocrit down? What's your platelet count? How are their electrolytes? So are you perfusing the gut? Are their kidneys well perfused? Do you have signs of liver failure? What's your blood gas? You know, we talked about blood gases before, so are they acidotic or alkalotic? Are they ventilating well? Are they have a metabolic issue? What's the chest x-ray look like? So is there new infiltrate onto the chest x-ray? Do you have significant cardiomegaly? Is the heart too small? Because with hypovolemia, actually, because the heart is not filling as much, you might actually see a smaller heart. And do they have any coagulopathies to make you think that perhaps DIC is developing? Any patient that presents in shock, remember oxygen, your best friend. 2 large bore IVs, ideally, especially if they're in decompensated shock. Typically, you'll treat most things with a 20 cc per kilo bolus of some type of crystalloid. You might need to repeat it 2 or 3 times. If they need additional support, consider perhaps giving additional agents. Examples of crystalloids would be like normal saline or lactated ringers. Remember, the child's cold to warm those up prior to the, because if you give a fluid rapidly and it's cold and the child's already cold, then you can make things worse. If they fail to respond after 2 or 3 boluses, consider adding another a colloid for more vaso expansion, like dextran, head of starch, plasma, or albumin. And then if they're losing blood, then you should return blood. So if after a couple boluses, if it's a multi-system trauma, hypovolemic shock from significant blood loss, then anticipate transfusing them with 10 cc's per kilo of packed red blood cells. Pharmacologically wise, I won't go into all the specific agents, but just kind of be familiar with it. I just want to more go over your receptors. So alpha-1 receptors, so if you have something that stimulates your alpha-1 receptors, then that causes vasoconstriction. Alpha-2 receptors inhibit the release of norepinephrine. Beta-1 is what's found in the heart, so if an agent that you're giving is a beta-1 agonist, then it increases the heart rate, increases the cardiac contractility, and increases conduction. If it's beta-2, then that's more in the lungs, so that causes vasodilatation and also bronchodilation. And then if it's dopaminergic, that's in actually the kidneys, the coronary system, and the cerebral vascular blood beds, so that can cause selective vasodilatation. But the dose of it depends on the location. So there's a kind of a renal dose, cardiac dose, so it's really dose dependent in terms of what organ system it's affecting. So different medications: dopamine, epinephrine, dobutamine, norepinephrine, dextrose, calcium, sodium bicarb, and head of starch. So just be familiar with all of them, you know, and your facility is going to be a little specific, your provider is going to be a little bit specific, but if you know the mechanism of action, think about if it's a, alpha-1, alpha-2, beta-1, beta-2, selective or specific agent, and then I'll give you an idea of what's the mechanism of action and in what scenarios would you actually anticipate that medication being infused. All right, that was a lot of information. Thank you all very much. I appreciate your close attention.